Hello everyone, this is Dr. K here. So the topic of our discussion today is Parkinson's disease. Now Parkinson's disease is a clinical syndrome which is characterized by bradykinesia, rigidity, that is increased tone, tremors, loss of postural reflexes. It is a neurodegenerative disease that primarily affects the movement of the body. It results from the degeneration of nigrostriatal dopaminergic neurons. With age, there is a progressive loss of dopamine, which is occurring naturally also. However, in the Parkinson's disease, this process gets accelerated. So there is a loss of dopamine and dopamine receptors in the basal ganglion. It is a progressive and an incurable disease with variable prognosis. What are the causes of Parkinson's disease now? So the causes are 80% of the cases are idiopathic in nature. Then cerebrovascular diseases can cause Parkinson's. Drugs and toxins such as metoclopramide, prochlorperazine, tetrabenzene, sodium valproate, lithium and manganese. Besides these, there are some other degenerative diseases such as dementia with Lewy bodies, progressive synuclear palsy, multiple systemic atrophy, corticobasilar degeneration and Alzheimer's disease are some of the other causes of Parkinson's disease. Now there are some genetic causes also, such as Huntington's disease, dopa receptor responsive dystonias, spinocerebellar ataxias, Wilson's disease and fragile X tremor ataxia syndrome. Besides this, it can be caused by anoxic brain injury and methylphenyl tetrahydropyridium, that is MPTP, also can cause Parkinson's disease. Coming to the pathophysiology of Parkinson's disease. So there are four main points we need to remember in the pathophysiology of Parkinson's disease. The first point we need to remember is depletion of the pigmented dopaminergic neurons in the substantia nigra. Number one. Number two, there is disruption of the basal ganglion circuit. So there is a basal ganglion circuit that exists normally in our body also. So there are two main pathways in this circuit. Look, the pathway includes a direct and indirect pathway. So the direct pathway facilitates movement in normal physiological conditions, and the indirect pathway inhibits the movements. So you can remember this by the mnemonic I for indirect and I for inhibits movement. So till here it is your normal function. Now let's look at the bottom. So this is what happens in Parkinson's disease. The direct pathway becomes underactive. However, the indirect pathway becomes overactive. Okay. So this was the second point. Third point, there is presence of alpha-synuclein and Lewy bodies in the nigral cells. Now what are Lewy bodies? Lewy bodies are nothing but an abnormal aggregates of the protein alpha-synucleins, and these are the pathological hallmarks of the Parkinson's disease. Now, Parkinson's disease is also recognized. This is why it is also recognized as a synucleinopathy along with multiple system atrophy and dementia with Lewy bodies, because it is a hallmark. And since there is a aggregate of alpha-synuclein, that is why it is called as a synucleinopathy. So coming to the fourth point, there is an imbalance between the excitatory and inhibitory receptors. So excitatory, we have acetylcholine, and in inhibitory, we have dopamine. So in excitatory, there is an increase in the acetylcholine, and in inhibitory, we have a decrease in dopamine. So this causes inhibition. I have also represented this graphically over here. Normally there is a well-maintained balance between the two, that is dopamine and acetylcholine. Now this does not necessarily mean that they are present in equal amounts in body. This just shows a balance between the two. And in Parkinson's disease, what happens is dopamine is reduced and acetylcholine is increased. Now coming to the clinical features. Now the clinical features, I have classified it into 3 or 4 main categories. First, we'll be talking about the cardinal features. Then we'll be talking about the motor, non-motor symptoms. We'll be talking about the motor symptoms. And then we'll look at the signs in Parkinson's disease. Coming to the cardinal features. So there are 3 main cardinal features in Parkinson's disease. First, we have bradykinesia, rigidity and tremors. And this forms a triad. Coming to the non-motor symptoms. Non-motor symptoms often precede the development of typical motor symptoms by several years. Next non-motor symptom is hyposmia. Hyposmia is there is decreased sense of smell. Then there is anxiety, depression and etc. These anxiety, depression, such symptoms are characterized under neuropsychiatric features. Coming to constipation next, which is a GIT symptom. Then we have REM sleep, behavioral disturbances, sphincter disturbances, sexual problems, weight loss, fatigue, and pain. Coming to motor symptoms, motor symptoms are almost always asymmetrical type. Now, first motor symptom we have is bradykinesia. Bradykinesia leading to micrographia, digital difficulty in tying shoelaces, difficulty in buttoning clothes, difficulty in rolling over in bed. Coming next, we have tremors. Tremors is another motor symptoms. Now, tremors is an early feature. Typically, unilateral resting tremors are seen in Parkinson's disease. These affects the hands, legs, that are the limbs, and jaw and chin, but they do not affect the head. This is the point to be remembered. Now, rigidity is another motor symptom. This causes stiffness and flexed posture of the patient. The patient often presents with a speech that becomes soft and indistinct. This is known as the monotonous speech. Now, cognition is spared in early diseases. Now, cognition of a person with Parkinson's is often spared. Coming to the physical signs in Parkinson's disease. Now, what is the difference between signs and symptoms is another side note I'd like to mention over here. Symptoms are what the patient presents to you with, the complaints of the patient. Signs are what you have to, as a physician, as a doctor, you have to look in the patient. So, these are the signs that you will be examining the patient for. Now, first, what are the general signs in patient of Parkinson's disease? The patient will have an emotionless phase that is known as a hypomania. Then the patient will have dysphonia, the stooped posture, impaired postural reflexes. Coming to the gait of the patient, the moment the patient walks into your OPD or comes to you with certain complaints, you will observe the gait of the patient. Such patients will present to you with a slow to start walking gait. Initially, when they'll start walking, it will be a slow gait. Then patient will have fascination, that is a rapid and short strides. Then reduction of the arm swing. So while walking, normally the amount of arm swing we're having, the patient will have reduced arm swing. Then there is an impaired balance on turning. So the patients might lose balance, or there is a tendency to fall upon turning. Coming to the tremors. So tremors are again of three types. We have resting tremors, we have postural tremors, and re-emergent tremors. So resting tremors are the most common type of tremors in Parkinson's disease. So they are 3 to 4 hertz. The postural tremors are of 6 to 8 hertz, and re-emergent tremors again are of 3 to 4 hertz. Now, resting tremors are of moderate amplitude. In fact, all these three are of moderate amplitude. Resting tremors are often asymmetrical. There is a pin rolling type of movement, affects limb, jaw, chin, but not the head, as we've already read earlier also. They are intermittent type, and they present at rest, since it's known as resting tremors, and are exacerbated on walking. Postural tremors, they are present as soon as the patient stretches out their arm, immediately on stretching. So postural tremors will be present. Re-emergent tremors, initially there is no tremor on stretching out of hand. However, rest tremors re-emerge after a few seconds. So these are your re-emergent tremors. They reoccur, they re-emerge after some time. Now coming to other signs that we'll be looking at in the patient, that is rigidity. So cogwheel type rigidity, there is rigidity plus tremors at the wrist joints. So this is known as cogwheel rigidity. Lead pipe rigidity is present at the level of elbows. Now the next sign is akinesia. Akinesia is a slowness of movement or fatiguing and decreased in the size of movement. We have normal findings also in Parkinson's patients. Since we have talked about so many abnormal findings, how do we differentiate it from other neurodegenerative diseases? So there are certain normal findings in Parkinson's patients, such as power and deep tendon reflexes, plantar reflexes, eye movement, sensory cerebral examinations will all be normal in cases of Parkinson's disease. Now coming to the investigations. We have diagnosis is basically mainly clinical. As soon as, like I earlier mentioned, as soon as the patient walks into your OPD, you will observe the gait, you will observe the facial features, you will look for certain signs, the patient will be complaining of certain symptoms. So all this will give you a holistic view, and you will most likely be able to diagnose it clinically itself. However, if required to perform certain investigations, we can perform structural imaging, that is CT or MRI. So they will show you, usually the findings will be normal for age, and they're rarely helpful. Next, we can do a functional dopaminergic imaging, that is SPECT and PET scan. These show abnormal finding even at the early stages, so these are usually more helpful, but can't differentiate between the various forms of Parkinson's. So there are several different forms of Parkinson's. We will not be able to differentiate between them using the functional dopaminergic imaging. Genetic testing can also be performed in such patients. Now coming to the management of Parkinson's patient, we have finally diagnosed the patient as Parkinson's disease. Now we have to manage the patient. So how do we manage it? We have pharmacological management, we have surgical management. So first looking at pharmacological management. So remember your second year guys, we read a classification of Parkinson's, anti-Parkinson's disease medications. So I have given that flowchart over here, taken from the pharmacology textbook. First, we have dopaminergic systems and cholinergic system. So the drugs used in dopaminergic system, affecting the dopaminergic system, are dopamine precursors, that is your levodopa. We have NMDA receptor antagonists, that is your amantadine. We have peripheral decarboxylase inhibitors, that is your carbidopa. We have dopaminergic antagonists, that is your ergot derivatives and non-ergot derivatives. Ergot derivatives include bromocriptine, perglotide and lisuride. Non-ergot derivatives include ropinirole and pramipexole. We have COMT inhibitors, that is tolacafone and entacafone, and MAO-B inhibitors, that is selagline and rosaglin. Now coming to your cholinergic system, now there are two classifications further in this drugs. We have central anticholinergics and antihistamines. Now central anticholinergics, we have procyclidine and trihexyl phenylidine, bisperidine, and antihistamines include promethazine. Now, how do these drugs work? This was just an overview of the pharmacological drugs, all the drugs that have been used in in treatment of Parkinson's disease. But which are the drugs and how are they working and what is the main functioning and what are they actually doing? I have represented here again graphically, taken from our pharmacological textbook. So this is your peripheral body cells and this is your brain. And here, right here, we have the blood-brain barrier. Now imagine the patient is taking levodopa, which is a type of dopamine precursor. So patient is taking levodopa, but however the 90% levodopa gets decarboxylated or is metabolized peripherally only. So it is not able to, so only 10% is going in, crossing the blood-brain barrier and forming dopamine in the brain. So 90% of the drug is wasted. So what are we supposed to do here is, we're supposed to give certain other drugs also which have a synergistic effect or an additive effect. So we are giving COMT inhibitors and we will be giving peripheral decarboxylase inhibitors. All right. So what are the peripheral decarboxylase inhibitors? We have already read over here, that is carbidopa, and over here we have COMT. We'll be giving, that is tolacafone and entacafone. However, if they are not given, what will happen in these in such cases? Levodopa in presence of COMT enzyme will be converted to 3-O-methyl dopa. So and again a metabolite of dopamine will be formed. And then levodopa in presence of DDC, that is decarboxylase enzyme, it will be forming dopamine. So we have to inhibit these two reactions. That is why I have mentioned this as 1 and 2. We will be looking at it shortly. In the brain, what is happening is levodopa is entering. Now we want this breakdown of levodopa to happen and form the metabolite, that is dopamine, which is required product. Now we don't want dopamine to further break down into its metabolites, that is in presence of MAO-B. So we have to cause an inhibition at this place. We have to inhibit this reaction, and levodopa again can break down and form 3-O-methyl dopa. So we want to inhibit COMT. So that is the role of these drugs. So we have seen we want to inhibit reaction number 1, that is COMT in both brain and peripheral tissue. We want to inhibit levodopa from becoming dopamine in peripheral tissues. That's why we are giving peripheral decarboxylase inhibitor, not central decarboxylase inhibitors. So that is number 2. And number 3, we want to prevent dopamine from forming its metabolites. So it is number 3. So these 3 places we want inhibition to happen. So the desired sites of enzyme inhibition are: number one, COMT inhibitors, that is we are giving tolacafone and entacafone. Number two, peripheral decarboxylase inhibition. Like I already mentioned, we don't want central decarboxylase inhibition, so that we're giving carbidopa, which is the most preferred drug. Then MAO-B inhibitors, that is selaglin and rosaglin. Now coming to further, treatment remains symptomatic rather than curative. We have already read earlier while reading the definition and the introduction of Parkinson's disease that Parkinson's is not a curable disease. All right. Now levodopa is the best tolerated, most effective and cheapest drug available. So that is why we are using this. What are the other advantages of levodopa? It is the immediate precursor of dopamine, has a general alerting effect. When given orally, 90% of decarboxylase is converted peripherally. So I have already told you about this. 90% of levodopa is converted to dopamine peripherally itself. That's why we are giving peripheral decarboxylase inhibitor to prevent this. That is, we are giving this with conjunction with carbidopa. Helps relieve akinesia and rigidity. What are the adverse effects of levodopa? Since it's such an important drug, we should always remember its adverse effects also. So it has we have two major adverse effects, that is at the initiation of this therapy and after prolonged therapy. So at the initiation of the therapy, patient can have postural hypotension, exacerbate angina, cardiac arrhythmias, nausea, vomiting, because it is going to affect the CTZ in the brain. After that, the prolonged side effects of this drug includes dyskinesia, behavioral effects, and fluctuations in motor performances. So patient is going to be alternately well, then stable, then again well. So the cycle is going to continue over here. All right. Next, coming to the surgical management. The surgical management includes destructive neurosurgery, was used earlier, so which is not done right now. This has become obsolete. Then striatortheric surgery. This involves deep brain stimulation. That is also known as DBS. It targets the thalamus, globus pallidus, and subthalamic nucleus. Intracranial delivery of fetal graft or specific growth factors. This is an experimental stages currently. It is not being performed in clinics and in patients as of now. MRI guided ultrasound induced thalassotomy is another surgical technique. Then we have supportive therapies such as physiotherapy to reduce rigidity, correct postures, then occupational therapy and speech therapy. Thank you so much. Like, share and subscribe my channel and comment down below what would you like to study about next.